Good morning, everybody. Thank you for joining us. We're going to begin in just a few moments. Good morning, everyone. Thank you for joining us. We're going to begin in just a few moments. Good morning, everybody. Welcome. We're going to begin in just a few moments. Good morning, everybody. We're going to go ahead and get started as people are filing in. Welcome to the next ASAP USA webinar. I believe this is our 55th webinar, so we're really proud to be here today with you. Today's webinar is Supporting Continuity of ART for People Living with HIV, and we'll be talking about successes and lessons learned. So thank you and welcome to all of our local partners. Please feel free to tell us where you're from, the organization and the country in the chat. We love to get a little sense of where everybody's from. As with all ASAP webinars, we're going to ask you to please use your Q&A box, which is at the very bottom of your screen, for all of your questions. That allows all of our presenters to be able to track your questions and answer them. Feel free to use the chat to talk to one another, but the Q&A box is really the best place for your questions. We have 4 polls that we're going to be running today. We'll have a general poll at the very end of the webinar, and then the USA team has 3 different polls to gauge your interest and knowledge on a couple of things. So pay attention to those. They're going to pop up on your screen. And today's presentation, as always, is recorded. And we're going to put it on the website, and you can also visit all of the other webinars that we have on demand in the resource library. We'll try and get that up by tomorrow morning. So as mentioned, we've had 55 webinars to date here with USAID ASAP, and we've had over 11,000 attendees. So thank you all so much for coming back and sharing these webinars with other people. We're here for you, so we're really happy to see you here today. Our webinars are available in 3 languages. First, we run them in English, and then we translate them into French and Portuguese. So please stay tuned for those coming up in the next couple of weeks. On the website, you can view both the slides and the actual recording of the webinar. And again, we get those up usually the day after the webinar is completed. And I'll be putting the link to that in the chat in just a few moments. And we know that you have great ideas for future webinar topics. All of our webinar topics have come from the community. So please feel free throughout the webinar and right now, go ahead and put some topic ideas in the chat. I make sure I record all of those and share that with the rest of the ASAP and USAID team. So thank you so much. So I'm really excited to introduce you to a few of today's presenters. From the USAID's Office of HIV/AIDS, Margaret Cunningham is an adult clinical branch intern, and Lana Lee is a medical officer with the adult clinical branch. And I'm going to go ahead and stop sharing my screen and pass it over to Lana or Margaret. I'm not sure who's up first, actually.
Hi, good morning, everybody. This is Lana Lee. I'm one of the, see if I can put on video, medical officers in the adult clinical branch. Here with Margaret Cunningham, who is also a clinical nurse and serving as our branch intern. And she'll help moderating. So for today's objective, we really wanted you to understand the current trends and metrics related to the continuity of treatment and what that means used by PEPFAR treatment programs. We also wanted to describe some common gaps and challenges and hear from you all as well as to common gaps and challenges to ensure continuity treatment for all PLHIV and some strategies to address and mitigate interruptions in treatment. We're hoping to describe some action steps and particularly learn from a couple of program partners that can be applicable for you all and in our discussion as well to learn how to improve continuity treatment and to mitigate interruptions in treatment in PEPFAR USA treatment programs. So as a reminder, we just wanted to ask that you feel free to enter your questions for the speakers in the Q&A box. We'll be monitoring that and we look forward to hearing from you. So quick agenda, I'll start off and kick us off with an overview of continuity of treatment in PEPFAR USA programs. We'll also have some information about from the SI team, Cody Adelson, and also have two program spotlights, one from Dr. Katie Simon, who is the medical director of Baylor Tingate program in Malawi, as well as from Dr. Emmanuel, who is the chief of party of KP Care 1 Heartland Alliance, Nigeria, as well as another final presentation from Lauren Bailey, who is an MMD advisor with the Office of HIV and AIDS, and with panel discussion and Q&A. So I'll just kick off. Just wanted to maybe start with a poll question for you all. So how frequently is the issue of continuity of treatment, otherwise known as retention, discussed or addressed in your treatment program? First response, we rarely have a need to address issues or challenges related to treatment continuity in our program. This is not a priority for our program. 2, we sometimes have a need to address issues or challenges related to treatment continuity in our program. Or 3, we have to address issues or challenges related to treatment continuity nearly every day. So I'll give you a couple of minutes to answer that. Susan, maybe if you wouldn't mind sharing.
Certainly. Would you like me to end the poll and share, or did you want me to read out the answers at this point?
Oh, sure, you can end the poll.
Perfect. All right. And then here's the results. Are you able to see it?
Yes, thank you.
Perfect.
Can others see it?
I believe
the most. Oh, great. Okay. So not surprisingly, we were into, this is somewhat of a leading question, obviously, given the title of the presentation. It is not surprising at all that this issue is, the issues related to treatment continuity and retention is an issue that all of you are working on each and every day. So if you close that poll, I can move on to the next next slide here. Can you all see my slide?
Perfect.
Okay, great. So as you're aware, as many of you may be already aware, PEPFAR's #1 treatment priority, as outlined in the COP guidance, is about supporting clients and the PLHIV by facilitating continuous ART. As of last year's MIR 2.5, I know MIR 2.6, the monitoring evaluation reporting guide, just got sent out. But as of the last version, continuity of treatment, there were some language changes. Continuity of treatment replaced the term retention, and interruptions in treatment replaced the term loss to follow-up. And the reasons for this, it sort of starts to come out in the COP21 guidance and COP20 and 21 guidance, where continuity of care is really being thought of as, requiring therapeutic alliance between the clients, healthcare providers, healthcare systems, and service delivery, other service delivery systems that support ART treatment to reach viral suppression. And the words retention and adherence were replaced by continuity of treatment, interruptions in treatment, to emphasize that therapeutic alliance being core to the importance of successful treatment for all PLHIV. So you'll hear me talking throughout this presentation about continuity of treatment and interruptions in treatment or treatment interruptions, to replace those terms, to start to shift some of that thinking as well. Sorry, trying to scroll through. As many of you are probably already aware in your own experiences in program, PLHIV experience ART, who are on ART, their experiences evolve throughout the treatment journey. And this is a recent paper that came out in PLHIV that really started to rethink the clinical cascade. Many clients experience disengagement and re-engagement from HIV treatment, and this disengagement and re-engagement may occur along several points, from diagnosis to finally being able to achieve long-term continuous engagement and adherence to treatment. It takes a lot of work to get there. Understanding that disengagement and re-engagement cycle is really critical to ensuring PEPFAR supported programs that remain responsive to PLHIV needs. And I think that we are, although our indicators predominantly really just look at a linear picture, we're starting to get a better sense of what this cycle may look like. If you look at the overall treatment program growth, the trends are important, very important for performance measures, but it doesn't tell the entire story of what may be happening within a particular treatment cohort. TX curve trends generally show steady growth over many years for most OUs, for most programs, but the TX new, you'll see in this dark green, the dark green boxes, often exceeds TX net new, which are the light green boxes you'll see here across the quarters, which suggests that there is some evidence of PLHIV who are experiencing disruptions in care and treatment. Now, TX net new does have limitations, especially when examining trends over time. You'll see, for example, here in Q1, a lot of times that tends to be the weakest quarter because of the holiday seasons, but sometimes it also happens because that is also a common time between fiscal years where projects end, where projects start up, as well as when geographic shifts or programmatic shifts happen. The other thing about net new is when we're doing disaggregates, like age band disaggregates, you really can't account for how many people are coming into an age band or coming out of an age band. So it's not a perfect way to judge how much a program has grown, but it is a general indicator of what may be happening. That said, most PEPFAR programs actually demonstrate very high continuity of treatment, previously known as retention proxies. The PEPFAR benchmark for continuity treatment is really 98% or higher. And you'll see here, we use a color coding where it's 95% and greater, but you'll see here the majority, all the programs are above 95%. Many, if not most, are above 98%. But despite that, TX curve the growth doesn't always keep pace with the expected growth of how many people we know are initiating treatment. So TXML and TXRTT, which are newer MER indicators, may help to paint a more dynamic picture of the treatment cohort within PEPFAR programs. You'll see here, this is in orange, a line of all the treatment by quarter that are being reported as having returned to treatment. And in blue are the clients who have who have experienced a treatment interruption, who is reported under TXML and the disaggregates of IIT. And you'll see that many PLHIV on ART in PEPFAR programs are experiencing either a treatment interruption or return to care. Nearly 1 million or more over the last 5, 6, 7 quarters. It did go up in Q3 when COVID started. But this is just to point out that, at any given quarter, they don't necessarily represent the same people, right? So we can't necessarily aggregate everyone and say that it's the same people or not the same people. But In general, at every quarter, we have a significant number of people who are churning in and coming out of the program. And these are, this is an important thing for us to learn from and to understand where that's happening, who that's happening, who is experiencing those changes. There are several reasons that we know for no clinical contact that are being reported through this TXML indicator. And this is reported, as I said, on a quarterly basis. These are not cohort indicators. So we, as I said, mentioned before, they don't necessarily give us a sense of, who's coming in, individuals coming in and out of programs. But across all ages, you'll see here in the dark blue and in the purple that interruptions in treatment make up the predominant cause for losses from the PEPFAR treatment programs. Data quality for IIT we know is evolving, but TXML interruptions in treatment disaggregates, IIT disaggregates, provide some additional data for us to understand the gaps and challenges that may hinder treatment growth and continuity. So you can't, one thing to note is we can't aggregate this over time. So you have to only be able, we can only analyze this really quarter by quarter to get a sense of who's coming, how many people are coming in and out of our program. So this brings us to our second poll question, if we can pop that up. Question is your program using TXML data? The first response is yes, it is our primary metric for retention or continuity of treatment. B is somewhat, we use a mixture of the retention proxy and TXML. And third is very little or not at all. We use a retention proxy or other data to assess continuity of treatment. So I'll give you another couple of minutes to respond. And if we can close that poll. Great. So the vast majority of you are using this metric, continuity of treatment, TXML as your primary metric for retention or continuity of treatment, which is fantastic. And also, and some of you are using it somewhat, you use a metric, a mixture of the retention proxy and TXML. You may also have some additional data. We do recognize that as partners or as implementing partners, you actually have probably better data in many ways than we have here at headquarters to examine who is losing, who's experiencing an interruption in treatment, who is returning, and then really tracking that to be able to assess sort of individually what needs may exist. And so we do expect that, while TXML is how we measure performance and we're looking at sort of global pictures, the data that you have is always very rich at a site level, at an individual level. Patient level data is incredibly helpful to have. And so we do, hope that you'll be able to share some of your experiences in the discussion or in your questions on how you're looking at your data. Okay, so next slide. One of the things that we have noted in our global looks at these IIT indicator is that the risk of treatment interruptions does seem to happen nearly almost 3 times greater. And this has been this is just one quarter's data shown here. But if you looked at it across all the different quarters, you will see that the risk of treatment interruptions are nearly 3 times greater for new clients on ART. You'll see, the TXML IIT is split up in such a way that you can get less than 3 months, report on those who have been on treatment for less than 3 months, and then those who have been on ART for more than 3 months, and then the total. And what we have done here to get the rates is to basically weight against the appropriate treatment curve denominator. So in other words, we weighted those who are less than 3 months on ART against the treatment new. And Cody Adelson, who's one of our SI advisors, will talk a little bit through how we do this or how we're looking at these indicators from the SI perspective in just a little bit. But just to say that the absolute number of IIT is the greatest among clients on ART for 3 months or more. There's a larger pool of people, and so it's not surprising to see that. But when you do weight it, PLHIV is who are new on ART are certainly experiencing greater rates of interruptions in treatment. And this really highlights the need really early on in treatment and engagement that there's a need for durable linkage and treatment engagement interventions early in the treatment journey. And MMD, for those who are, just to note that MMD for those countries or programs that are implementing MMD for people who are newly on ART or early in their treatment course, it may actually mask early IIT because you're not capturing IIT. You won't actually be able to capture when they come in for their medication pickups earlier, but it might be a little insufficient to prevent IIT unless there's some additional support and contact with patients that is being provided. The other thing that I wanted to say is that this pattern that we see with new clients really is across the board. If you look on the left, this side shows the number of patients of those PLHIV who have been on treatment for less than 3 months and who have experienced interruption in treatment in Q3. And you'll see that, you know, there seems to be the bulk of the people definitely lie within sort of that young adult age range. But when you actually weight it according to, as I mentioned, in terms of the rates of treatment interruptions, you'll see that it's nearly identical across all the age and sex bands. And so it's like this flat line right on both left, on the male side and the female side, and sort of across all the age bands. And I think what this is showing us is that it's really critical that we are looking at client-centered approaches to prevent IIT for new clients across all age and sex populations. So those first 6 months, 12 months, really critical for durable linkage and engagement on treatment. The other thing when you look at clients who have been on treatment for greater than that, the pattern changes a little bit in terms of who is experiencing treatment interruptions more frequently or more likely. You know, when we look at the volume of clients, the number of patients who were reported as having IIT, you know, that bulk, as I mentioned before, it shifts a little bit between males and females. Males a little bit older males a little bit older than females. But the rates of interruptions in treatment is really high amongst that 20 to 29-year-old age range, and a little bit above for the males and a little bit below for the women, you know, in terms of age band. So I think that while the highest rates of IIT are among young men and women between the ages of 20 to 29, we don't have a lot of interventions specific to focusing on young adults' access to ART and appointments. I think we might have a few examples in the program highlights, but again, would love to hear some great examples from how you are looking at your data within this age category, as well as how you're addressing that. All of that said, I do want to mention that we do see quite high rates of interruptions to treatment amongst young children. This 1 to 4 category tends to be quite low, or tends to be quite high in terms of interruptions. And I also want to point out that while, you know, older PLHIV, those 50 plus, you know, may have lower rates of interruptions in treatment, they do experience, because they're such a big group, you know, the volume of people that who may be experiencing IIT in that older age category is pretty significant. I have heard there may be some kind of belief that older people don't fall out of care, and that is not true from what we can see in our data. And so all of this to basically say, when we're looking at our data, it really does help us to tailor the appropriate responses and to understand what is happening in order to address the issues. Mitigating IIT is really a best practice and a PEPFAR priority. Both the WHO and PEPFAR guidance really emphasize the importance of tracing and tracking immediately patients who are not linked to ART, as well as those who have experienced interruptions in treatment, meaning they have not shown up for a medication pickup or for a clinical appointment where they would get access to their ART. Understanding the root causes really helps to lead to treatment interruptions are really critical to ensure that all PLHIV and your programs are responsive to ensure continuous access to HIV treatment, and in order to achieve that ultimate goal, right, of durable viral load suppression. Returning and successful re-engagement to HIV treatment is also really critical. How we do that is something that we're paying a lot of attention to as well, to ensure successful long-term treatment outcomes so that IIT doesn't happen again. On the right here is just one example you'll see on the PEPFAR Solutions website. It's a little bit older, but an example of a loss to follow-up algorithm and tool from PEPFAR Zimbabwe. Kind of hard to read, apologies, but the link is down below on the slide if you want to take a closer look at that. So just in summary, treatment growth and continuity remain really critical to achieving 95, 95, 95 and to maintaining epidemic control. We are looking at the TXML indicator and its proxy metrics for IIT, as well as TXRTT, to provide some additional information on which clients are at greater risk of experiencing treatment interruptions, and trying to get a better sense of where and how people are returning. PLHIV who are newly initiated on ART deserve some special attention and support to ensure continuity treatment. In our COP21 work 20 and 21 work plan recommendations, we did include something called a first 180 days package, where it really is just how your program could potentially increase the amount of support that a newly initiated person can receive some support. As I mentioned earlier, young adults are at highest risk of IIT, and better identification of and tailored interventions will have significant impact on treatment continuity for this population. But there are definitely other subpopulations, including young children, PLHIV, older PLHIV, who should not be forgotten. MMD and other differentiated service delivery models may help overcome barriers to ART, as we'll see from Lauren Bailey's presentation. But we also have some vulnerable populations, like key populations, who may not have the required additional support. Now, prior to 2.5 MER 2.6, we didn't have a KP disaggregate for IIT, but we do actually have, in one of our program highlights, Dr. Manuel to talk about some of the programs and interventions that they are doing in their program for KP. So I'm going to hand it over to Margaret to read off and lead into Cody's presentation. Margaret?
Thank you so much, Dr. Lee. And as a reminder, if you have any questions for any of the panelists, please do drop them in the Q&A box, and we will get to those during the discussion section following the speaker presentations. So please have a look for the final poll question, which is regarding your program's use of the TXML and TXRTT data. How confident do you feel with the quality of data that you're reporting out, and how that is usable for program planning? Options are very confident. Our site level TXML data are probably the most accurate way to monitor interruptions in treatment or IIT. There's the option of somewhat confident or minimally confident, with concerns about completeness or accuracy. And as a reminder, your answers are confidential.
Great, so results are coming in. They're pretty neck and neck. Let me know when you'd like me to share them.
We'll give everyone another moment. Go ahead, let's see the results. Okay, so as expected, quite a mix, addressing some of those issues that Dr. Lee talked about, but most of you are very or somewhat confident with the quality of these data to use in planning. So thank you everyone for responding. And thank you again, Dr. Lee, for this great overview. We will be, next up on our panel is Cody Adelson, who is a data analyst with the USAID Office of HIV/AIDS and the Strategic Information Team. He focuses on supply chain, multi-month dispensing, and treatment continuity analytics. Cody, if you're ready, you can go ahead. Thank you.
Great, thanks, Lana and Margaret. So hi everyone, as Margaret mentioned, my name is Cody Adelson, and I'm a data analyst with the Strategic Information Team here at the Office of HIV and AIDS. And so now I'm going to talk a little bit through a quick overview of the MER indicators that Lana's been discussing here, surrounding treatment continuity, what they measure, and then some examples of how we analyze them, as well as data completeness and how that sort of impacts interpretation of these indicators. So when we think about the treatment cascade, we often think about this in sort of an ideal sense of a linear process from disengagement to awareness to engagement and subsequently viral load suppression. But when we talk about continuity of treatment, we're really looking at the cycle of patients who've experienced a treatment interruption and then those who then re-engage back onto treatment. So in terms of the MR, as Lana has sort of alluded to, we capture those through both the TXML as well as the TXRTT indicators. So when we gain someone on treatment, that's either counted as a TX new if they are sort of a treatment naive patient who's not been on ART previously, or through TXRTT, which is someone who is then back on treatment after having been lost previously or who's experienced an interruption in treatment. And then for those who've lost clinical contact, we measure that through the TXML indicator, which is then further disaggregated by the reason of why a particular patient has dropped off. And one of those reasons that we'll get into in a minute that we tend to focus on is the interruption in treatment. And then finally, the TX Cur indicator is just an overall measure of the size of the cohort or the people who are currently on treatment and receiving ART. Next slide, please. So here we're looking at all of the disaggregates for each of the indicators in the treatment cascade. So as you can see, they sort of differ somewhat by indicator. I'm not going to go into all of them, but you can just sort of use this as a reference. And obviously, they're also included in the MR indicator reference guide, which goes into greater detail on each. One thing I will note, though, is that all of the indicators on treatment are only reporting numerators. So when we're calculating the percent treatment interruption, which I'll talk about in a bit, that's actually a derived calculation that's not actually in datum by itself. Also to point out that the total numerator here represents the overall top line for each disaggregate. So the total numerator is a good reference when reviewing data quality and completeness for other disaggregates. So for example, for the MMD disaggregate, which is the age, sex, ARV dispense, that should add up to the total numerator because it should sort of encapsulate the total number of people on treatment. But some we wouldn't expect to. So for example, the KP disaggregate, we wouldn't expect to add up because it's just looking at the KP population. So for TXML, the disaggregate ART no contact reason specifies the reason why someone has dropped off of treatment. So two of these, so the interruptions in treatment 3+ month, as well as the less than 3 months, are disaggregates again that we particularly look at because it measures those who were either previously known as lost to follow-up or who experienced interruption in treatment. Next slide, please. So taking a bit of a closer look at those two, we use the IIT disags to calculate the percent of total patients who are lost to follow-up. So each of those calculations use slightly different figures for the denominator, whether it's the less than 3, 3+, or total. But in general, it's just important here to know that they're calculating what is the total proportion of the number of people on treatment that have been lost to follow-up in a particular quarter. And that can be divided up to either look at only patients who've been on treatment for less than 3 months or those that have been on treatment for greater than 3 months or the total number. So in terms of percent interruptions in treatment, there really are no targets. Ideally, obviously, we'd like to see them as low as possible. In the past, we've used 2% as sort of an informal benchmark for sort of what constitutes better performance. But really, just it's important to keep in mind reporting over time and just to keep trying to obviously lower that figure as much as possible. Next slide. So here, just to quickly summarize some of the main MR updates from 2.4 to 2.5. So for TXRTT, or again, the number of patients that have returned to treatment, it was added that the patient needs to be on ART and then drop off of treatment before the start of the reporting period. Once they did return, it's required that they remain on treatment until the end of the period. And then for TXML, or the number of patients that have lost clinical contact, it was also clarified that the patient needs to have been on treatment at the beginning of the reporting period or initiated during the period. So essentially what those two things mean is that a patient can't be double counted as both TXML and RTT. You're either classified as TXML or TXRTT. And so for the newest round of the 2.6 updates, which haven't taken into effect yet, but the main changes here will be that the TXRTT has now been updated to include an additional disaggregate for the duration of interruption in treatment. And TXML will now have an additional category. So rather than just less than and greater than 3 months, it will have less than 3, 3 to 6, and 6+. But you'll receive some much more detailed guidance on this to come. Next slide. So the treatment waterfall is kind of a nice visual to see how those indicators and disags work in the context of looking at overall treatment trends. So on the left, you see the dark blue, which we have as the previous quarter's TX curve. And then again, as I mentioned in the light blue, we see the increases both of the TX new or the treatment naive patients who have been added to TX curve, as well as those who have come back through TX RTT. And then in orange, we can see all the people who have left treatment, which are separated out by all the different disags of the TXML disaggregate. So we've talked a lot about the IIT less than 3 months and 3+ months, but we also have deceased, transferred out, as well as stopped treatment. And finally, we have unattributed loss or gain, which is sort of the difference between what these sort of figures add up to and what the actual TX curve is. And that's sort of a bit of a reflection on the data quality here. So if there's a large unattributed loss or gain, that would mean that there's probably some data quality issues with either the added patients or with the TXML lost patients. Next slide, please. So now here we're taking a look at the TXRTT or the returns data in green, as well as the TXML interruptions in treatment in the dark blue since FY20. So when we refer to the program churn, what we really mean is the total number of unstable clients or clients that are either being lost to follow-up or just returning after being lost to follow-up in a previous quarter. And obviously those groups are sort of associated with increased vulnerability. So for example, as a proportion in Q3 FY21, a total of 929,000 are in that churn, which accounts for 5.3% of the total PEPFAR TX curve. So that's another way that we sort of look at this data to get an overall view of the total number of patients that are either coming or going. Next slide, please. So here we're looking at data completeness by OU. So in the left column, we can see the percent of sites reporting on IIT. And then the middle is restricted to only the larger sites or the percentage of sites that have reported greater than 1,000 TX curve. And on the right, we have the overall percent IIT. So what we can sort of see here is that the OUs with 0% and a couple with 1%, IIT look to have the lowest reporting completeness for sites in general, as well as those larger sites having reported more than 1,000 TX curve, while the sites with higher IIT tend to have better reporting. So when you're taking kind of a deeper dive, it's really important to look into this data and sort of take into account data completeness, because it really looks like it does influence percent IIT, and that's why reporting completeness is really important, because if it's low, it's much more difficult to interpret. And what we'll see often as well is underreporting, which is also important to identify, which is when we'll see, a really large facility, for example, with a TX curve of 7,000 with only 1 or 2 or 3 IIT, which is probably not that realistic, and also a sort of data quality issue. Next slide. And finally, this is just showing that relationship over time. So we have on top the number of interruptions in treatment and the percent IIT. And then on the bottom, we have reporting completeness and how that changes over time. So again, what we can see is that when reporting completeness decreases by about half between FY20 Q4 and FY21 Q1, it looks like there's been a really large boost in the in performance and a large drop in IIT. But obviously it's probably a result of less facilities actually reporting IIT rather than a legitimate actual drop in treatment interruptions. Next slide. Yeah, and that's all I have from my end.
Thank you so much, Cody, for that thorough overview on metrics. We'll be moving on to our next speaker, is Dr. Katie Simon. Dr. Simon is a pediatrician with over 9 years of experience working in Malawi with Baylor College of Medicine's Children's Foundation's Malawi on HIV clinical care and treatment programming. She has served as the medical director for the USAID-funded Tingate Outreach Program since 2014. And this program currently supports the full cascade of HIV care and treatment services in 118 health facilities across 7 districts in Malawi. Dr. Simon.
Thanks so much. And thank you for the opportunity to share some of our experiences. I'm presenting on behalf of a big team. Next slide. So this is just a quick overview of some of what we'll share today. And we're really excited for the dialogue with other programs, because I know that all of the folks on this call have a lot of experiences to share and challenges to discuss as well. So I will start with a quick background of our program and some epidemiology and clinical cascade data, and then spend the bulk of the time discussing our approach to promoting retention in treatment, continuity of treatment, and some of the challenges, highlights, and successes we've experienced. Next slide. Baylor College of Medicine Children's Foundation Malawi, or Baylor Malawi, has been a leader in pediatric, adolescent, and family HIV care since 2006, when we opened the Clinical Center of Excellence, which has grown to be the largest pediatric outpatient ART clinic in Malawi. And since then, Baylor's supported services have really expanded from just pediatric clinical care to include provision of acute inpatient pediatric care, obstetrics and gynecology, pediatric oncology, and surgical services, in addition to delivering comprehensive care to people living with HIV and their families. The programming that we'll talk about today is really focusing on our support through the USAID-funded Tingate Core program, where we support over 200,000 people living with HIV, of whom over 30,000 are children and youth. Next slide. At the core of our program are our large team of community health workers who have been supporting the health system in Malawi and providing client-centered support since 2007. And we currently have over 900 Tingate community health workers supporting the cascade of HIV care. So we'll talk about their role in continuity of treatment. Next slide. And as already mentioned, currently we're supporting actually 95 health facilities in 6 districts with a goal of helping families to live healthy, fulfilled lives through development and implementation of innovative programming, building local capacity and sustainable health systems, and delivering high quality services. And you can see on the right a map of Malawi with the shaded in green districts being those that we're currently supporting. Next. So this slide is just demonstrating our current treatment cascade in those supported districts. And we're quite proud to share that at this point in these 6 supported districts, 94% of PLHIV know their HIV status. 98% of those are living with HIV are receiving treatment, and 94% of people on treatment have suppressed viral load. Next slide. This is just a quick snapshot of our current cohort growth over the past 2 years. And we'll talk a lot more about this, but what is most notable and what we're most proud of is that despite many of the challenges related to the COVID pandemic over the past 2 years, we have managed to maintain pretty steady cohort growth, which of course is the result of initiating new clients on treatment, but a lot of work related to continuity of treatment, which is obviously what we're focusing on today. Next slide. So now I'm going to shift gears and talk about the programming and what our approach is to treatment retention. And there's sort of three pillars to this. The first being a client-centered, evidence-based approach that is based on understanding what clients need and desire, and then developing and implementing tailored approaches based on this. And we'll talk about how we do that. And delivering this at sort of three critical time points along this continuum that we saw in the slides, I think that Dr. Lee shared with clients sort of cycling in and out of care. With the goal, of course, first being prevention of treatment interruption, where we create lasting engagement from the first encounter with the health facility, but recognizing that there are challenges that everyone experiences. So mitigating those challenges, rapidly identifying clients when they miss an appointment and re-engaging them. And then if they do end up truly interrupting treatment, welcoming them back to care and engaging them upon return to identify those challenges and prevent future interruptions. And then the third pillar of this is really the data piece, which is using our performance data to continually evaluate, optimize, and improve programming. And when I say performance data, not just looking at client treatment interruptions and continuity, but also looking at the feedback we're getting from clients themselves on what their needs are and whether we're meeting those or not. Next slide. So just a quick word on what client-centered care means. There's many different definitions and quite a bit of evidence demonstrating how important this is that I think we're all familiar with, but at the core of it really is making sure that we're treating clients with dignity and respect, sharing enough information with them so that they feel empowered to participate and collaborate in their care. So the critical piece here is understanding these needs. And there's a few ways that we do this. The first is through exit interviews, and these are both anonymous and in person. The anonymous exit interviews are conducted via phone and essentially just involve asking the client several questions about their treatment experience, asking for suggestions, and then using that information. We also conduct intermittent informal interviews with health facility providers, both clinical and lay health workers, to understand their perspectives on what clients need. And then the third piece is really the core of our programming, which involves client-specific counseling. And this is through what we call our Takulandi Rani or welcome service that I'll explain a bit more in a moment. But this is a counseling and support model that really empowers clients to build treatment resilience by explicitly addressing their anticipated reasons for treatment interruption. And then using this information, we are then able to develop and implement interventions that are targeted to client needs. And there are different levels of this. Some are facility level interventions and others are very, very client specific. Next slide. So this is just an example of a piece of that understand segment. The word cloud at the top right, apologies, it's a bit small, but this is feedback from our clients. These are reasons that have been shared for treatment interruption that these clients have shared with our psychosocial counselors. And you can see that there are a lot of different reasons, but there are common themes that come out in the larger text. And these range from challenges around disclosure and stigma to concerns about safety to more logistical issues like cost of transport, length of travel to facilities, challenges with scheduling. We have a lot of clients in areas where they'll travel for farming for extended periods of time or travel to South Africa and will be unable to make the appointments that are made for them. So understanding what these barriers are is critical to designing a treatment plan for that client that will facilitate continuity of treatment. Next slide. Just a couple couple examples of responses to these needs. This slide is just showing how different DSD models can actually facilitate age and gender appropriate care by providing care at convenient times and locations. And I think this is familiar to everybody. Examples of this within our program include what we call our ICAT clinic, or Intensified Care ART clinic, where clients who have more complex medical needs are clustered on specific clinic days to receive additional time and attention. Other examples include male-specific clinics, which have been put in place in response to desire by men that they have clinics at different hours or different days, separate from perhaps the pregnant women who are coming in. And then other examples extend early AM, evening hours, family and child clinics, teen clubs, community ART distribution, etc. Next slide. This is just another example of using a DSD model to respond to some of those client-specific needs and how that impacts continuity and treatment. This graph is showing data from a subset of 12 sites where we looked specifically at the 12-month retention of clients receiving 6-month scripting, and saw that those who were receiving 6-month scripting in these facilities had 96% 12-month retention as compared to a 12-month retention of 73% among the overall ART population. Next slide. Another example here of a DSD model promoting continuity of treatment is in our adolescent programming. So looking at our retention of adolescents in care, we have a 5% interruption in treatment. And at facilities that have teen clubs, which at this point are the majority of our facilities, there's only 1% interruption in treatment. And there's a number of reasons for this. And this programming was developed in response to feedback from these adolescents and the providers who are caring from them. But essentially, it boils down to providing training and sensitization of the lay and clinical health workers, in addition to the guardians and teens, in order to address common adolescent challenges such as disclosure and really engage adolescents to be proactive in their care. There's a lot to talk about here, which we can perhaps address in Q&A, but the bottom line is, as with any other population, really listening to what the teens want. We conducted exit interviews and found that many of them requested phone follow-up between visits for additional psychosocial support. Many of them desired multi-month scripting. And being able to provide some of that through our teen club model has helped as well with treatment continuity for this cohort of youth. Next slide. All right, so those were just a couple of examples of DSD models that were designed based on the exit interview feedback. Now I just wanted to describe a little bit more about our Takulandirani Welcome Service and how it interacts, how clients interact with the facility at various timeframes along this continuum of care. So we'll go through prevention, which is really targeting client-centered care at their first interaction with the facility and preventing interruptions in treatment, and then moving on to mitigation and welcome. Next slide. So looking first at prevention, we have a package of services as part of our Takulandirani Welcome Service that's offered to every client who initiates treatment for the first time, as well as clients who have previously interrupted treatment and clients with a high viral load. And this, for these new clients, I'll talk about first. This includes a consultation with a psychosocial counselor. It includes, of course, I should have mentioned this first, but a clinical triage with assessment for comorbidities, advanced HIV disease, and referral and treatment for clinical stabilization first, but also a lot of psychosocial support. They receive retention-focused client empowerment health talks, and then a community health worker is assigned to the new client to provide ongoing support and counseling, which they receive at each of their initial visits for the first 6 months in treatment through their first viral load result. The community health workers can provide appointment reminders for clients with phones who desire the reminders. And then really at the core of this is the counseling that the community health worker provides with the use of a job aid to talk through the client's anticipated barriers and proactively develop a plan to address some of them. Next slide. If a client does miss an appointment, the next step is mitigation. So this is where we use the EMR data to look at which clients have missed appointments. And then based on that information, the community health workers can then call the client within a day of missing. And again, at 7 days if they haven't yet returned, and conduct physical tracing for those who don't have phones, which is actually the majority of our cohort. And the goal here is to help clients return to care before they miss ARV doses. Many, many clients actually miss appointments because they still have pills, but they haven't yet missed a dose. So bringing them back to care before there's a true treatment interruption. Next slide. The final piece of this is welcoming clients who have truly interrupted treatment back to care, and really trying to shift the approach here from a punitive, judgmental interaction with the facility to something where we're welcoming them back to care, acknowledging that treatment continuity comes with challenges. Everybody has challenges. We're here to support this process, and then really working together with the client to figure out what their barriers are and how we can support them to stay in care, recognizing that some people have very logistical challenges that are easy to address. The example I gave previously of somebody who travels for 5 months of the year to farm, for whom a 6-month script might be a perfect solution, to a client who has a much more complex social situation and has not disclosed to their partner and is concerned about their safety. And that would require a significantly different approach with a lot of psychosocial support and ongoing planning. Next slide. So this slide is just demonstrating the impact of our interventions to promote treatment continuity. This is our 1 and 3 month retention over the past 2 years. The blue line is 1 month retention, the red is 3 month retention. And you can see that we have had a nice trend upwards since the introduction of this programming, even despite the multiple challenges that COVID has placed on the system, on our clients, on our health providers. Next slide. And this is just looking at treatment interruptions. This is our active cohort from last quarter of this year, where we had only 4% of clients experience a treatment interruption. Next slide. Now, just to wrap up, the third piece of the third pillar I described is really CQI. So using data to continuously evaluate, optimize, and adapt our programming. And this involves feedback from the exit interviews and information from the clients, as well as looking at our data. Next slide. So just one example of this is using TXML to demonstrate interruptions in treatment and identify which clients are experiencing higher treatment interruption rates and inform tailored retention interventions. So you can see in the graph on the left, this is men only, that the red bars reflect men aged 20 to 34 years, and they have a higher rate of interrupting treatment, 7 and 8%, than the other age groups. So looking at this, we were able to conduct some targeted exit interviews with men accessing our facilities and try and really establish if there were other interventions that we could have put in place to help address some of these barriers. And to do this, we used the EMR to generate missed appointment lists. We aggressively tracked those clients to find out what their challenges were. And then, as I mentioned, conducted exit interviews. And the result of this was actually the introduction of some of those male clinics that I mentioned earlier, as well as really focused counseling to help clients advocate for multi-month scripting or for changes in appointment dates that work for them, among other interventions such as community ART distribution to bring services closer and extended hours to facilitate men who are unable to access clinics during regular hours. Next slide. Okay, so that was a whirlwind tour through our our approach to treatment continuity, just a couple key points. The first being that client-centered care delivered across the continuum and continuously evaluated by robust CQI is really critical to promoting continuity of treatment within our program. And this requires client-centered engagement from the first care encounter via our community health worker-led client-centered counseling and support, which enables people to anticipate and address challenges before they emerge, and then along the continuum. And this client-centered care through our welcome service identifies individualized solutions to promote retention. Thank you so much for your attention, and I will hand it back to Margaret.
Thank you so much, Dr. Simon, for that insightful presentation. We are lucky enough to also have another program spotlight, and this is from Dr. Godwin Emanuel at the Heartland Alliance. Dr. Emanuel is a public health physician with several years of experience working and defining public health interventions in Nigeria and globally. He has strong awareness of population health and development issues and has tenaciously worked with several NGOs, currently with Heartland Alliance as chief of party, to establish and broaden the scope of comprehensive HIV social, legal, and economic service packages for key populations, sections of the general populations, adolescents, and children in Nigeria. He has served in several national health technical committees saddled with formulating HIV treatment and policy guides for the country. Dr. Emanuel.
Okay, checking my mic. Good afternoon, everybody. From the Heartland Alliance team, we actually want to say a big thank you to USAID for giving us this opportunity to share our work. So I actually am presenting on behalf of a very large team, and I'm sure my colleagues are also here to help out with questions on the chat box. Next slide, please. So just as a background, it's blurred, I can't see. Okay, thank you. So just as a background to the program, it's actually, I'll say the largest KP program in the sub-region, the Key Population Community HIV Services Action and Response, KP Care 1 program. It's a 5-year project. It's very important to say that this particular program is actually in its 12th year because it was transited from another KP program managed by Heartland Alliance. So this particular mechanism under different names have been in place in the last 12 years in Nigeria. Currently, we work in, I'll call it 60 sites because I know the audience we have is diverse. So local government area, I'll use them as sites. We work in 60 sites and we work in 3 states of Nigeria. Basically, the goal of the project is to reduce HIV incidence, mortality and morbidity amongst key population as well as sexual partners and children. Breaking all the barriers, social barriers and biological structural barriers that actually creates or puts a key population individual in the risk of either transmitting or acquiring HIV. The project is very comprehensive. We provide a wide range of services, comprehensive HIV services from across all the 95, 95, integrated with cervical cancer, viral hepatitis, gender and post GBV management, sexual and reproductive health, of course, human rights and advocacy. If you want to implement a very successful key population program, of course, the TB component is also very strong. Our target populations are there: men who have sex with men, female sex workers, persons who inject drugs, of transgender persons, and people who are incarcerated. Next slide, please. Again, I'll skip this slide, but just to say that the program is actually expanding geographically to other regions from the COP that starts in a couple of days. So we're expanding to additional 3 states in Nigeria and over 50 sites in those 3 states. Next slide, please. So this is just trying to show some level of epidemiology and clinical cascade data. The dark green is a treatment growth, the percentage across one COP between October last year to September this year, and the lower bar, the lower shade green shows the continuity in treatment. So steadily the program has grown, and currently we have over 50,000, 55,000 KPs on treatment on the program. To my right is clearly just showing clearly some of the in quarter 3, the interruption in treatment we have had. So if you look at the bar to my right, our program is actually provided within the context of a one-stop shop. So where a KP individual has access to a wide range of mutually reinforcing services, treatment to social services to legal services. So we call that model a one-stop shop model. So that within the space the KP can get all the required services. So the services are provided in different geographical locations with their own peculiar challenges. So in terms of interruption in treatment, these are quarter 3 data, and we had those different levels in terms of numbers of people who had interruption in treatment, and they have geographical variations and geographical reasons why that happened. And as I go on, I'll be able to speak to that. Next slide, please. Also, the trend of the clients that had IIT from quarter 1, quarter 2, and quarter 3 of this particular COP has also been reducing, because we have been doing a lot of looking at our data, analyzing, finding out what are the issues, and trying to fix those challenges. So the data at the top there, it's for those that had IIT with over a 3 months period after initiation on treatment, and the lower bar, if you can see, very little, 3, 2, 3, 1, and 2, 3 again are the ones that we lost just within the first 3 months of treatment initiation in quarter 1, quarter 2, and quarter 3. Interesting to say that again, we have looked at the issues we had in quarter 1, why we had those interruption in treatment. We were able to address them in quarter 2, and gradually in quarter 3. The numbers we have in quarter 4, though quarter 4 is we're still putting our data together, is far lesser than what we have in quarter 3. I'll also be sharing some of the solutions and ways we have gone about making sure that we drop these numbers. Next slide, please. So this is still just trying to show the geographic distribution of the numbers we lost, that had treatment interruption. And if you understand Nigeria very well, looking at the picture of the map, it's easy to see where those challenges are, and what are some of the reasons. So just to speak to some of the reasons that we had the treatment interruption in the places where we had them. So in the place called Eket, some of the issues we had there, a lot of them are onshore workers. So intermittently they go into the sea for their work, and most times they don't even have the time to communicate with the care providers to let them know that they are going. And when they are there, it's difficult to even reach them. We've had some very serious communal clashes in those local governments, and at times it's very difficult for care providers to find their ways into those local governments to provide care. So clients can't come out to the center, and it's also very difficult for care providers to reach out to them. The other place where we had quite some numbers in Lagos, 18 clients, and some of the challenges we have there, one of our biggest problems there is actually the mobility of key population individuals. So Lagos is cosmopolitan, and key population individuals are on treatment, keep moving from one place to another. People change their phone numbers, because they are leaving a particular hotspot to another hotspot. At times they decide to change, their numbers and all that, and it's also times quite difficult to reach them. So you need to find somebody that knows that person, that knows that another person that can help you reach out to that person. So for Lagos, we've had quite some numbers as well. Lagos and Akwa Ibom, those are the two terrains where we've had some level of interruption in treatment, and because of some of those peculiarities, which I'll talk about how we have been able to address them going forward. Next slide. So some of the approaches we have used to really drill down on this and ensure that we reduce the number of clients that experiences interruption in treatment. We have what we call enrollment follow-up calendar, where we consolidate everything that has to do with the client the moment you get into treatment. It addresses all your concerns around ARVs, side effects, and all the other issues that a client might face when they are enrolled into treatment, things like disclosure, fears and all that. And we also work at clients through ADR so that they are aware that these are the possible things that could come up and all that. Because we've also, in terms of when we interacted with clients, we discovered that some of them just decided to stop treatment and decided to abscond because of some of the challenges they had, when they started taking the medications, and the treatment literacy was not so deep. So now we have developed, a calendar that speaks to all the possible issues that you have, and a care provider will walk you through the issues and hand over that little calendar to you, so that, and there's a number you can always call just in case you have issues with medication. There's something we call it the ABCDEFGH strategy. We call it be ready to identify needs and preference. So what are your support systems? How do you prefer to be served? Where do you want your drugs? Is it at home? Is it in the office? So what support structures do you have? And we do what we call preemptive client tracking, because as we review our case notes, we are able to predetermine some of the kind of clients that most likely we are going to lose to that we might lose in the course of providing care, or might have some level of treatment interruption. So like I said, for example, if I enroll a client that is an onshore worker, at the moment you say you are your occupation is you have something to do with onshore offshore kind of job, we know that this is a potential high risk, and we need to be very focused and narrow the care to make sure that we meet that particular individual's need. So we have done some profiling. For example, I speak to maybe a sex worker, and we know that based on our interaction, she's extremely mobile. We'll put in some checks to make sure that when she moves from one particular hotspot to another, we can be able to track. Of course, multi-mod scripting has done a lot of work for us positively, because of the peculiarities of the communities we work with and the individuals we work with. We've been able to use multi-mod scripting to help. We have care and support systems. We have community-based organizations that provide some level of local care and support systems. These CBOs are very localized to the different typologies of key populations we work with. So we have an MSM CBOs managing, we have MSM CBOs that manage the needs and peculiarities of MSMs. We have female sex work CBOs, so they provide direct care and support to individuals within that community who are HIV positive. We also do courier services. So if an MSM decides to move from one region to another, and we are able to find out early enough, we do a lot of courier services where we courier medications to members of our communities that we serve. The D is that we have decentralized support group system. I know support group is probably not new to a lot of us. So we have decentralized support group system where people are now in groups of 5, 10, depending on how the size that can be managed, and within the support group, we deploy a lot of, wraparound services to keep them together, psychosocial and mental health support, which is H, and we do H appropriate disclosure, depending on how comfortable that client is. And, members of that support group has also played a very key role in helping other clients to disclose, fellow clients to disclose to either family members or friends or whoever they think they want to actually disclose to. So there's a lot of support structure within the support group of KPs who are positive to help support the new members who are coming into those groups, and that has really helped to stabilize our numbers a lot. So engagement with a KP living with HIV and AIDS for feedback. So we have, regular client satisfaction surveys that we do, and we analyze the feedback. You came into our one-stop shop. Are you happy with the services? Was it too long? For those that are actually receiving services outside the one-stop shop structure at the community level, we also deploy those client satisfaction forms to help, regularly retool and, refine our service delivery models. We also deploy call center. So we have a very unique way of deploying call center services to make sure that, for those that we provide services to within the community, we have a unique way of reaching them. We call it the call center service. It's not a big, in quotes, call center, but it's something that is designed and, very functional within the program, where we have a group of persons who are, designated with that responsibility or assigned that responsibility to put out frequent calls. And so when we profile a client and we know that this client has a tendency, based on what we have seen and what our data is showing, that this client might easily, have treatment interruptions. Those ones, they get more frequent calls than the others. For those with family, we provide family-centered care. Currently, we also enroll pediatrics into the program, mother family peer, just to make sure that if a mother is positive and the child is positive, they can also receive care within the same space. And we have what we call adolescents, youth, and the clinic is very friendly, and we have actually differentiated both clinic times and clinic visits to accommodate. We have a very strong young population. About 20 to 30% of our clients, around that figure, between 20 and 30% are very young. So we have been able to design our clinic as to respond to their needs. And we have specialized platforms, WhatsApp platforms, where issues around adolescents are discussed. So they have their own special platforms that peculiar issues are discussed. So we have something we call the FSP. We call them focus service providers. These are and we have a lot of them on the program. I think this is one of the biggest wins on the program, where clients are divided into cells, cell formation. So we break them into cells of 10, 20, and location based, and we attach a focus service provider that can provide a wide range of services, trained to provide a wide range of both clinical and non-clinical services to that particular cohort or that cell. So we have a lot of these FSPs in the community, and you have your own 10, 15, 20 clients that you manage. So yours is to make sure that they get their ARV refills. You troubleshoot for issues around GBV, you troubleshoot for other both clinical and non-clinical services, and you draw the required technical persons to go provide that service to members of your cohort. And this is one particular thing that has really helped us, to reduce our clients that have had or having interruption in treatment. Again, the project is very comprehensive, and because we provide a lot of wraparound services, mental health, very, very critical to the success of the project and keeping those over 50,000 clients on treatment. Because we provide all these wraparound services, cervical cancer intervention, we do cervical cancer screening, and a program for the men. We have a special package that we call Men's Health that addresses some very unique issues around men's health, sexuality, libido issues. So there are a couple of things we address within that particular portfolio that has helped to keep our clients. And of course, again, we do some level of hepatitis testing, and we do accompanying referral if there's a need. Next slide, please, as we move. Next slide. So I'll try to be a bit fast. Okay, so understanding IIT. So we set up IIT teams, tax team in each of our one-stop shop. They are tasked with they do gap analysis on weekly basis just to ensure that they are monitoring the progress of how clients are moving, and those things I talked about. If there's any potential leak, they point it out to the clinical team, and those guys will jump in and ensure that things are done. I've talked about tax shifting. Okay, the tax shifting. So those CBOs and local partners we use their offices as well as DICs where we do drug deliveries and people come in there to pick up refills. So the project is very decentralized so that every pickup is as where you want it. You can get it wherever you want it, and we can deliver to you. We do reviews to make sure that we check those that are transferred out, those that have stopped treatment, and we have regular mortality reviews to look at those we have probably lost to death, very little, less than 0.005 of the clients over the last decade. So line listing of defaulters, like I said, very strong data analysis and flexible client-centered services, which I've also mentioned. Next slide, please. As I'm looking at the time just to make sure that. Again, so I think I've talked about this. We do a needs assessment as soon as you come in. We have your follow-up calendar. We do counseling. We do preemptive tracking. We support with MMD. So this is just the flow. And we have an individualized care plan for every person. You have your refill calendar. And when it's time for viral load, as you start in, there's viral load education. We talk about sample collection. We even discuss sample collection as early as possible. Where will you want it? How will you want it? How convenient will it be for you? We discuss your treatment plan with you, and try to create some milestones that will keep you in treatment. For those who are lost and when they come back, we do supportive return back to care. Try to troubleshoot why they left, and find very creative ways of ensuring that they don't leave the program again. We also engage treatment champions to support others, like I've said. And of course, the MMD is there, and we do well-based courier services, and we also track referrals. Next slide, please. Okay, I think because of our time, this is just our follow-up calendar.
Dr. Emmanuel, are you, we can't hear you anymore. Oh, I don't know if we might have lost a connection with Dr. Emmanuel. Maybe we can just use this time to take a little bit of a pause as he comes back. Hold on one. Just as a reminder also about we're getting some really nice Q&A in the Q&A box, so please feel free, as well as comments. So please feel free to share any comments or experiences from your own programs in the chat box, any specific questions in the Q&A.
Sorry, I was thrown off. I think I'm back now. So next slide, please, if you can hear me.
We can hear you. Thanks, Dr.
Sorry. Next slide.
Did you want to review the follow-up calendar?
Okay, so so the follow-up calendar basically on day one, the focal service provider places a call to the client same day after enrollment, just to reassure the client. On day 5, the focal service provider will place another call to check on the client, around issues around adherence, and if you have had any, adverse drug reaction, and talk you through it. On day 15, the focal service provider again places a call in just to check on the client and to ensure that the client is on medication, is staying on medication, and if there are any issues, side effects that you want us to talk through, we talk through them. On day 20, the focal service provider, will call and now invite that client officially to a support group meeting based on location, based on KP type, and on day 29, the focal service provider checks again if there are ADR issues, and for after a month. So this is the intense follow-up calendar we use for the first month of enrollment. No matter where, if you're enrolled at the community level, or no matter where initiation is started, you have to go through this as part of the initiation process. So next slide, please. So as we wait for the next slide, so if there are issues, if we're not very comfortable with this, we still run through it again for another 1 month. Again, so for adolescents, we have flexible and extended clinic hours. We have community center activities. We have AYP club support groups, and we have treatment bodies, peer-to-peer refills. We do home deliveries. We do a lot of social media stuff just to keep our clients, up to date with, issues around treatment and treatment literacy and provider-led behavior change communications. Next slide. So just basically at the site level, we have a CQI team across all the one-stop shop. We also do our both site weekly performance review with our activity manager at USID. We have a platform that is called the KISS platform, where we report. It's an online reporting platform that was developed in conjunction with the activity manager at USID, where we monitor on daily basis what is happening to the program. If there's anybody that is supposed to have had refills and wasn't done, the KISS platform will flag it up. So we have those different platforms. We do monthly meetings where community will use data and some level of analytics to look at issues around care to identify gaps. We identify specific gaps, and we try to address them. We share these improvement plans, and we set targets for the different teams and successes of teams who have done very well in keeping all their clients on treatment, or who have been able to bring back the clients that had interruption in treatment. We share quarterly, and and do some form of reward, just to keep, to motivate the team. And where there are best practices, we make sure that we share the best practices across the entire team so that other team members can learn from all the over 80 sites where we are working. Next slide, please. So challenges, of course, for a key population program, we still have issues around stigma and discrimination. The second one, which is very heavy, is the high mobility and the difficult terrains where we work in. Of course, we still have issues around with pill burden. People still tell you, I need to carry this from one place to another. My work is a mobile kind of work, so there are always pills in my bag, and I need to take this every day for the rest of my life. So that's one of the things we face. Law enforcement issues. So there's still some level of criminalization of some of the acts, and once in a while, we get some bashing with law enforcement agents, and we need to address some of these issues. So some of the solutions we have used, we do a lot of advocacy, legal literacy. We engage a lot with state actors. We have actually evolved the program. It's a very dynamic program, and it's heavily community-centered, community-driven, and we take feedback a lot from the community to refine the program. So our treatment literacy and peer support program has really helped, and we have done a lot of work engaging law enforcement agencies to help reduce the constant issues we have with the law enforcement community. Next slide, please. So I want to thank USAID for their time and for the opportunity given to Hartland Alliance to share from the work we do. Over, please.
Thank you so much for another very insightful program spotlight. I think we're getting a lot of really excellent conversation in the chat box and in the Q&A box. So as a reminder, continue to send your questions to the panelists. Our final panelist today is Lauren Bailey, who is the multi-month dispensing advisor at USAID's Office of HIV/AIDS. She has nearly a decade of experience supporting global HIV/AIDS programs, and she holds a Master of Science from the Harvard T.H. Chan School of Public Health. Over to you, Lauren.
Thank you so much. You can advance to the next slide, please. All right, so we'll begin this discussion by giving a quick overview of some PEPFAR program data related to MMD. So in this slide, we see the percent of ART clients on MMD by number of months of ARVs dispensed. So as a quick overview, we measure MMD coverage as the number of clients on MMD over the total number of clients on ART. So we understand that this proxy measure for coverage is imperfect, as many of the clients in the denominator are not technically eligible for MMD. But this is a way to standardize the measure of coverage across countries, knowing that MMD eligibility criteria varies from country to country. So what we see in this visual is the quarterly proportion of clients on MMD. And we see that the top color block within the bar represents the unreported clients. And then the maroon color is the proportion of clients receiving less than 3 months dispensing. So those clients are not considered to be on MMD. The light blue is the proportion of clients receiving 3 to 5 month dispensing. And the dark blue represents clients receiving at least 6 months dispensing. And I also want to flag that this aggregate data do not include South Africa. So we can see that MMD coverage has grown tremendously from FY20 Q1 when PEPFAR began collecting MMD data. This is largely plateaued from the FY20 Q3 COVID surge. It's also important to recognize that we need to ensure that all clients are reported into the TX Current Mmd disaggregate. This ensures that we have an accurate picture of what actual MMD uptake looks like. Next slide, please. So this slide shows the quarterly MMD coverage and absolute numbers of clients on MMD. So the PEPFAR program has added over 4 million clients to MMD since FY20 Q1. And it should say that this is nearly doubled the number of clients on MMD. So my question is, how can we accelerate MMD growth, particularly 6-MMD, and ensure that all eligible clients who desire to have access to extended dispensing intervals have that access? Next slide, please. So this visual shows FY21 Q3 country level MMD coverage performance. So we had internally set 2 benchmarks for MMD coverage for the entire population. So the first one being achieving 50% 6-MMD coverage in FY21, and the second being achieving 90% 3+ MMD coverage in FY21. So we can just kind of see a snapshot of where the countries are in terms of performance. And as you can see, coverage really varies from country to country, but we have some countries that have done a phenomenal job in scaling 6-MMD. And other countries have done a really good job of scaling 3 to 5 month dispensing, but need to begin transitioning clients to longer dispensing intervals. And then we also have some countries that are a little further behind in scaling 3 to 5 month dispensing, and other countries that really need to focus on improving their MMD reporting. Next slide, please. So this visual, which is similar to the one previously shown, but this shows the quarterly pediatric, so clients under 15 years of age, MMD coverage and absolute number of clients or children on MMD. So as we can see, PEPFAR is struggling to scale pediatric MMD. The program has had a substantial bump in coverage during the FY20 Q3 COVID surge. Excuse me. However, coverage and the absolute number of children on MMD decreased for the first time in Q3 this year. So again, as a reminder, coverage is likely higher than what is reported here due to the imperfect proxy measure, but it is still concerning to see a downtrend in coverage this quarter. So again, another question to consider is, what barriers are we facing in terms of scaling up pediatric MMD? Next slide, please. And this is just another visual to show where we are in terms of pediatric MMD coverage at the country level. So again, we can see performance varies across countries, and we also set a target, an internal target for 3+ MMD pediatric coverage at 65% this year. And we can see a number of countries have achieved this target or have nearly achieved this target. Next slide, please. All right, so that's it for looking at the program data. So before we dig into the rest of the presentation, I wanted to kind of share with you a list of key components that we've identified that are necessary to scaling MMD. And this is not an exhaustive list, so I encourage any of you to type into the chat box things that we may have missed here. But some things to consider include if the country has an enabling policy environment and clear guidelines that dictate, who is eligible for MMD and what dispensing intervals are permitted. Additionally, there needs to be strong supply chain management at all levels. And this includes, procurement of commodities, stock analysis, supply planning, distribution, et cetera. Additionally, we need to have an efficient and well-equipped laboratory system. As we know, many countries require a client to be virally suppressed in order to be eligible for MMD. So we need to ensure that, our machines are working appropriately, that there is an efficient specimen transport network, and turnaround times are, not prohibiting, access or rather viral load results. Additionally, we need to have a trained health workforce. So healthcare workers need to be knowledgeable on MMD guidelines and the benefits of MMD, and there needs to be a system in place for identifying and enrolling eligible clients. Additionally, we need to have empowered patients who have strong treatment literacy and who can demand MMD. And finally, there need to be tools and technology for monitoring and supporting all aspects of MMD implementation. So I've placed in red the topics that we're going to discuss in the rest of the presentation. So next slide, please. All right, so in this slide, we have a snapshot of what MMD policy and eligibility criteria look like in select PEPFAR countries. And I want to note that what I'm sharing are national guidelines, and this does not account for any temporary policy changes due to COVID. So we can see in Ghana, for example, they permit 3 to 6 month dispensing. And in order to be eligible, a client has to be on ART for 12 months. They need to be virally suppressed, no treatment failure or resistance issues. And in terms of children, children 5 and over are eligible, and clinically stable pregnant women are eligible. If we look at Kenya, Kenya is only technically permitting, per their national guidelines, 3-month dispensing at this point. And in order to be eligible, you need to be on ART for 12 months. You have to have an undetectable viral load, no active OIs, you need to be adherent to your scheduled clinical visits. And children over 2 are eligible, so under 2 ineligible, and pregnant and breastfeeding women are ineligible for MMD. Now, if we look at criteria for Lao, they permit 3 to 6 month dispensing. And similarly, you have to be on ART for 12 months, no adverse drug reactions, good understanding of lifelong adherence, virally suppressed, and pregnant and breastfeeding women are ineligible. And then finally, in the DRC, we see that they permit 3 to 6 month dispensing, and you need to be on ART for 12 months, virally suppressed, no OIs in the last 3 months, no adverse reactions. Children under 2 are ineligible, so children over 2 are eligible, and pregnant and breastfeeding women are eligible. So that just gives you a flavor of what eligibility criteria looks like in each country and how it varies. Next slide, please. All right, so in this slide, we see the updated WHO guidelines that were released, I believe, in April of 2021, which shows their updated definition for established on ART. And as many of you know, a client needs to be clinically stable or established on ART in order to be eligible for multi-month dispensing. So one of the big changes to note from the previous guidelines is that the minimum time on ART has been reduced from 12 to 6 months. And as we saw in the previous slide, national guidelines in many countries still require a client to be on ART for 12 months, but per the new updated WHO guidelines, they've reduced this to 6 months. Additionally, included within the definition of established on ART are a number of subpopulations, including individuals receiving second and third line regimens, PLHIV with controlled comorbidities, children and adolescents, pregnant and breastfeeding women, and key populations. So I think this represents, an opportunity for the countries that you work in to really advocate for updated guidelines that reflect this more inclusive criteria. Next slide, please. So in addition to analyzing country level policy, I wanted to share some highlights from the current MMD literature. So I've heard from a number of countries that the countries might be hesitant to scale MMD due to a fear that MMD might negatively impact viral load suppression or treatment continuity. So it's important to note that several studies have found that continuity of treatment of viral load suppression remain high and non-inferior to the standard of care with 6-MMD. So in this particular study, which was conducted in Lesotho, I believe, 30 facilities in Lesotho were randomized to 3 arms. There was the control arm, which was facility-based 3-MMD, and then the 2 experiment arms, the second one being community-based 3-MMD, and then the third being community-based 6-MMD. And the study found that there were no significant differences in retention and viral load suppression for stable HIV-infected participants receiving MMD within the community-based differentiated models when compared to the facility-based differentiated models. Next slide, please. All right, so the interval study, which was conducted in Malawi and Zambia, had a similar setup to the previous study. So it was a cluster randomized non-inferiority trial, also conducted at 30 health facilities. And it compared 3 ART dispensing strategies. The first being the standard of care, which was based on provider opinion, and then a 3-MMD arm and a 6-MMD arm. And the participants were all virologically suppressed adults on first-line ART and not pregnant and breastfeeding. And the primary outcome in this study was retention at 12 months, and this did not include viral load suppression. But the study found that 6-month dispensing was associated with a 9.1% absolute increase in retention and care at 12 months after model entry. Next slide, please. So this is the most recent study of the 3 that I'm sharing, and this one is out of Haiti. And this study looks at rates of retention among clients newly initiating ART enrolled on MMD. So different from the other studies in that this is looking at clients who aren't necessarily clinically stable. So this study found that extending ART dispensing intervals increased the probability of retention at 12 months after ART initiation with up to a 24.2% point increase in the likelihood of retention. It also observed statistically significant gains to retention with MMD with up to an approximately 4-month supply of ART. So the bottom line being MMD for ART is an effective service delivery strategy that improves care retention for new ART recipients. Next slide, please. All right, so now we can look at what the PEPFAR data tell us about MMD and viral load suppression. So it's important to note, first of all, that we cannot infer any type of causal relationship between MMD and viral load suppression from this data, as this is only program data and we did not conduct an actual study. But what we can tell from our PEPFAR data is that as rates of MMD coverage have increased, we have not seen a subsequent drop-off in viral load suppression rates. So we see in red, that is the proportion of clients receiving at least 3-month dispensing, and then the green represents viral load suppression rates. And at the very bottom, we see the absolute number of clients receiving MMD. And I also want to point out that this visual does not take into account viral load coverage or the TLD transition, which, as we know, can both affect viral load suppression. It also does not incorporate the lag time between MMD enrollment and next viral load test. So that's an important thing to consider as well, as when a client is initiated on MMD, they might not receive their viral load test for, maybe at least another 6 months down the road. Next slide, please. So this is a really unique visual that our colleague Cody helped to create. So this visual shows interruptions in treatment and 3+ MMD levels. So as we know, we've kind of set a target of achieving less than 2%, a rate of 2% IIT, and we've established a target of about 90% 3+ MMD coverage. So we can see in this animation each quarter how countries shift on this map. As MMD grows, we see a number of countries reduce their rate of IIT. And again, we can't really infer a causal relationship here, but it's fascinating to see that as MMD coverage grows, a number of countries have been able to achieve an improved rate of IIT. Next slide, please. All right, now we're going to look at a specific example from Uganda. So Uganda recently released, or not so much recently, excuse me, in February 2021, released a circular with specific changes to their MMD policy. So the first change to their policy has to do with delinking viral load testing from MMD. So previously, the ARV supply dispensed to a client depended on their next viral load due date. So for example, if a client came in and their next viral load was in 2 months, they would get a maximum of 2-month dispensing. But under the updated guidelines, clients can now receive a 3- or 6-month dispensing irrespective of their next viral load due date. Additionally, the guidance now suggests in an effort to promote treatment continuity for clients newly initiated on ART, that MMD is now available to clients newly initiated on ART. So at the time of ART initiation, clients can be given about 1 to 2 months supply of ARVs. And then 3 months after initiation, the client should be offered 3 to 6 months dispensing if the client has both tolerated the ARVs during the first 3 months on ART, and the client has been linked to peer support and psychosocial support. Next slide, please. So we can see in this visual that the policy update has really helped to accelerate MMD coverage in Uganda. And I'll point to 2 different time points in this visual. So we can see the first red line in between Q2 and Q3. That signifies when Uganda released some COVID-related guidance to its MMD, or COVID-related adaptations to its MMD policy, making the policy more inclusive. And we can see an immediate bump in Q3 to MMD coverage. And then after that, coverage kind of stalled and there wasn't much growth. But then sometime in February, so during FY21 Q2, the Uganda Ministry of Health released the updated guidelines related to MMD, and we see how that really helped to accelerate MMD coverage. And I also want to note that in addition to updating these policy guidelines, these policy changes need to be accompanied by supportive supervision and continuous quality improvement visits, as has been done in Uganda. And this helps to ensure that these, new policy guidelines are being implemented, across sites, and they're being implemented with fidelity. Next slide, please. Oh, I think we may have missed a slide. Oh, one more ahead. Oh, I think a slide got removed. I apologize. So I'll just go ahead and read this slide out loud. I have it in my slide set, but not in yours. So I wanted to just discuss briefly what are some patient and provider concerns about MMD. And this is to get to, why there might be some hesitancy in rolling out MMD. So what I've heard, or what the team has heard, is that, from providers, that MMD, unless contact with the client, might lead to adherence issues and a risk of IIT. Additionally, there's some fear that children have weight-based dosing changes that might make MMD a challenge. There's the fear of running out of stock. Also that there aren't proper tools for monitoring MMD, and there might be storage issues at the facility level. And in terms of patients, we've also heard that, with MMD, there might be a feeling of abandonment, a need for support between ART pickups, stigma or fear of unintended disclosure, some storage challenges, and also poor treatment literacy and or understanding of MMD. So in this slide that's being projected right now, this slide directly gets at the issue of weight-based dosing changes to children and how this isn't necessarily a deterrent to enrolling kids on MMD, because as we can see in this visual, there are only 6 changes anticipated during the first 10 years of a child's life. And as we know, most children aren't even eligible for MMD until they're 2 years old. So really there's at most 4 changes to a child's treatment regimen in the first 10 years that they're on MMD. And additionally, at the bottom, we can see that DTG-10 has been introduced in a number of countries, and what dosing changes might look like for children on DTG. Next slide, please. So now that we've established that MMD is feasible for pediatric clients, how can we enhance provider and patient knowledge of MMD for children and adolescents living with HIV? So EPIC, RISE, and ACHIEVE have developed a suite of materials to help support the scale up of MMD to children and adolescents with HIV. And the goal of these tools is to educate and encourage discussion about MMD between providers, caseworkers, counselors, caregivers, and children and adolescents with HIV. And these tools are designed to address several of the questions that I had posed in the previous slide. So these tools are currently available in English and French and have been field tested in both Nigeria and Burundi, but can easily be adapted to meet your country's context. Next slide, please. So just to quickly discuss what's available in this package of tools, there's a technical guide for healthcare workers for assessing MMD eligibility and prescribing 3-MMD and 6-MMD to children and adolescents with HIV. There's also a technical guide for community health workers to understand the importance of MMD and to understand their role and responsibilities in supporting MMD for children. There's a job aid for healthcare workers, caseworkers, and other counselors to discuss MMD with caregivers, and a job aid for healthcare providers, caseworkers, and other counselors to discuss MMD with children and adolescents with HIV. There's also 2 handout brochures called, entitled MMD of ARVs in You, and one's for caregivers and one's for adolescents. Next slide, please. So finally, just a question to pose: how can these tools possibly be incorporated into your work? So many countries have capitalized on the TLD transition as an opportunity to help scale MMD. And, we think that, as pediatric DTG-10 is introduced, this can also be an opportunity to scale pediatric MMD and also utilize the information, education, and communication tools that I just presented to ensure the responsible adoption of MMD among children and adolescents with HIV. So I welcome also any thoughts and recommendations on how your team or country can possibly integrate these tools into their work to scale pediatric MMD. Next slide, please. I believe that's it for me. All right, thank you so much.
Thank you again. Thank you, Lauren, and thank you to all of our panelists. This has been a really fruitful discussion. As a reminder, we will be sharing all the presentations will be shared by ASAP, and we'll attempt to put together a summary of some of the questions and answers that have been coming through the question box. We're getting close to time, also just wanted to remind everyone to respond to the poll questions. I guess we can, you know, given the short time, I think we can just go back to our panelists to see if there are any summary or closing remarks that that our presenters wish to add.
I just wanted to thank all of our presenters again as well on behalf of ASAP and OHA for providing a really nice snapshot to some of the work that you're doing. We know that continuity of treatment and the work to mitigate and interruptions in treatment and also bringing back people to care and re-engaging is, as I had said earlier, quite a priority and a difficult and somewhat challenging sometimes. I don't have any other final comments, just want to really appreciate everybody's. One thing I did want to note was, you know, there was a comment, Lauren, I don't know if you saw this from Dr. Simon about the barriers to pediatric MMD and a significant challenge with regards to the global supply chain for pediatric ARV stocks. And I didn't know if you had anything to respond, if you wanted to respond to that in the just briefly.
I was actually just highlighting that, and I was going to drop it into my notes because I had noticed in the last quarter a rather precipitous decrease in pediatric MMD coverage in Malawi. So it's interesting to hear that this is in fact due to you know, pervasive supply chain issues of the pediatric formulations. This has happened in other countries as well. Typically, then they do rebound. But I'm very saddened to hear this, but curious, you know, how the country is hoping to address this issue, and also what Malawi's plans are for integrating pediatric DTG, and if maybe this might help, you know, resolve these issues, or if you foresee continued issues with the supply chain management.
Love to hear from other countries as well. I can say from the Malawi perspective, I think it's very much been a global supply chain issue. So the country has done a great job of relocating stocks to ensure no actual stockouts, but it just has meant for a lot of children and teens who aren't on the fixed dose combination of tenofovir 3TC DTG that they end up getting hopefully 2, but sometimes even 1 month scripts. In order to make sure there are no stockouts. So hopefully the global supply chain will be able to keep up. But if anybody has additional insight on that at that level, that would be great to know. Thanks.
And Katie, we can follow up with our supply chain colleagues here at USAID and see if we can add any additional context to that question and concern when we send out notes to the Q&A as well with the meeting. So we'll make note of that. Thank you.
Thank you again, everyone. If there are no further questions or no further closing remarks, we can close out the session. We will do stay tuned for the recording and for the slides, and we will attempt to follow up with a summary of questions and responses. Thank you again, everyone.